Hello, my name is Nicole Chang, and I'll be presenting a diagnostically challenging case of seronegative systemic sclerosis with features of CIDP. To start with some background, systemic sclerosis, or SSC, is a rare autoimmune disease that typically affects the skin, lungs, heart, GI tract, and kidneys. Neurologic manifestations, however, are much less well described in the literature. In terms of serology, most patients with SSC test positive for anti-nuclear antibodies, but about 6.4% are ANA negative with other autoantibodies, and fewer than 2% are negative for all known markers. CIDP is a progressive demyelinating neuropathy, often linked to other autoimmune diseases, but its association with SSC has not been well established. Our case highlights this unusual overlap between seronegative systemic sclerosis with CIDP features, underscoring the diagnostic challenge and the need to consider neurologic involvement even in antibody-negative SSC. Our patient is a 70-year-old Black man with a history of hypertension, hyperlipidemia, and COPD. He presented with 6 months of progressive dyspnea, a 30-pound unintentional weight loss, edema, skin tightening with hyperpigmentation, and SVT. In addition, he developed a severe bilateral ascending sensorimotor neuropathy that ultimately led to immobility and areflexia. We did an extensive workup that was most consistent with seronegative systemic sclerosis and chronic inflammatory demyelinating disease. Workup ruled out other autoimmune processes, malignancy, infection, neurological diseases, endocrinopathies, and vitamin deficiencies. Imaging showed pericardial and pleural effusions, as seen in Figure 2, and lymphadenopathy without malignancy. Labs revealed elevated ESR and CRP, positive RF and CCP, but negative ANA and all SSC-specific antibodies. Kidney showed proteinuria, but no alternate cause. EMG demonstrated severe axonal polyneuropathy, and CSF showed albuminocytologic dissociation. Skin biopsy was consistent with systemic sclerosis, and he was ultimately treated with mycophenolate, IVIG, and rehab therapies, and then discharged with rheumatology and neurology follow-up. The histology slides seen in figures 3 and 4 demonstrated superficial displacement of eccrine glands and thickened collagen bundles consistent with SSC. To synthesize this presentation, this comparison table outlines expected findings in systemic sclerosis, in CIDP, and in our patient. Briefly, serology in SSC is usually positive, but our patient was fully seronegative. Neuropathy is uncommon in SSC, and when it does occur, it's usually axonal or ischemic in nature. In contrast, CIDP typically presents with symmetric demyelinating neuropathy and CSF showing albuminocytologic dissociation. Our patient had an unusual overlap of axonal EMG but CIDP-like clinical and CSF features. This case emphasizes that seronegative systemic sclerosis requires high suspicion and often biopsy, especially in Black patients who are more likely to be seronegative and have severe disease. What makes this case particularly unique is the dual diagnosis of seronegative systemic sclerosis and CIDP. This overlap is exceptionally rare. Most reports of connective tissue disease-associated CIDP involve Sjogren's syndrome or SLE, but not systemic sclerosis. Importantly, our patient's neuropathy was profound and proximal, not the mild distal neuropathy usually described in SSC. Pathophysiologically, this raises interesting questions. Peripheral neuropathy in SSC is usually attributed to microvascular dysfunction and fibrosis, leading to axonal injury. CIDP, on the other hand, is driven by immune-mediated demyelination. Our patient appears to represent a possible convergence of these mechanisms. Finally, while multi-organ involvement in systemic sclerosis has been well documented, the contribution of the nervous system remains comparatively understudied. This case highlights the need to better understand neurologic manifestations in systemic sclerosis, especially when they mimic other immune-mediated neuropathies. This case raises several important questions. First, what pathophysiologic mechanisms underlie this overlap? SSC-driven immune dysregulation may be triggering an autoimmune attack on peripheral myelin, overlapping with typical axonal neuropathy. Second, can biomarkers distinguish axonal SSC neuropathy from CIDP? Candidates like neurofilament light chain, GFAP, and GDF15 may help detect PNS involvement, though classic demyelinating antibodies are often absent. And third, what is the role of standard CIDP therapies in this context? IVIG may help, but evidence is limited. In summary, 1. Systemic sclerosis can present without serologic markers, and tissue biopsy may be essential for diagnosis in the setting of high clinical suspicion. 2. The coexistence of seronegative SSC with CIDP-like features is exceptionally rare and underscores the importance of considering neurologic involvement in systemic sclerosis. And 3. This case highlights the need to better define mechanisms, biomarkers, and management of neurologic disease in systemic sclerosis. Thank you.